Now I'm going to take about bipolar affective disorder. As myself Angel, working as assistant professor, mental health department in ES College of Nursing. First, we are going to see about objectives of bipolar affective disorder, introduction, definition, types, etiology, prevalence rate of bipolar affective disorder, epidemiology of bipolar disorder, symptoms of bipolar disorder, causes of the disorder, prognosis and management of bipolar disorder. Introduction of bipolar disorder. Bipolar disorder, which means the major psychiatric disorder, and it is the most common psychiatric mood disorder. About the 1 to 2 percentage of in India live in bipolar disorder. Bipolar disorder is a mental health condition. It is otherwise known as a mood or affective disorder, and also it is known manic depressive illness. Earlier, we know a bipolar disorder, manic depressive psychosis. And definition of bipolar mood disorder. Bipolar, it is a mood or affective disorder. It is characterized by significant mood swing that can range from high to low. Bipolar disorder, it is having there are two different level of poles. One is high and second one is low. In high mood it is called as manic episode, and also low mood it is called as depressive episode. If patient having the high level of mood, it is called as manic episode. If patient having a irritability and also the excitement. In low mood, in depression episode, patient having a like hopelessness, helplessness, the person not interested to any activity, and it is characterized by a recurrent episode of mania and depression in the same patient in different time. It is called as bipolar disorder. Next, move on to prevalence rate of bipolar disorder. The lifetime prevalence of bipolar disorder is about 4%. According to Global Burden of Disease, the study shows that in the year of 1992-2017, it done the study, it gave the result of acute prevalence rate of depressive disorder as 3.35%, and largest contributor to non-fatal health loss affecting 4.4%. In India, 2017, some study shows 45.7 million people suffered from depressive disorder, and bipolar disorder had prevalence rate of 0.6%. The lifetime prevalence among 14 to 18 years olds are affected in bipolar disorder, and 1% or sub symptoms of affecting 1% of bipolar disorder, and also 5.7% the life prevalence among the age of bipolar disorder. And also mean age of onset of bipolar disorder 10 to 12 years, and it is around 25 years also. The men typically have an earlier age of onset than women. Then 18 years in men and 20 years in women. The women are more experience many more episodes in given a year compared to the men. The first episode usually in depression episode only. Epidemiology. The epidemiology of bipolar disorder affecting men and women equally, as well as all race, ethnic groups and socioeconomic classes. Bipolar disorder often develop in a person late teens or early adulthood. At last, of all causes start before the age of 25 years. However, some people have their first symptoms during childhood, while others may develop. Okay, who's at risk? The bipolar disorder often develop in a person late teens and early adult age. At least half of all cases start before 25 years. Some people have their first symptoms during childhood, while others may develop symptoms late in life. Suicidal risk. The prevalence rate of attempt suicide in bipolar II and bipolar I disorder, appearing to the similar 32.14% and 36.3% of affecting of risk of suicide. However, the latency of attempts may be higher in individuals with bipolar II disorder compared with bipolar I disorder. Seasonal affective disorder, vulnerability to change in sunlight, especially fall and spring. Prevalence rate of 4 to 6%, found more often than north latitudes. It is presenting in north latitude. Here the people are affecting 4 to 6% of prevalence rate of bipolar disorder and seasonal affective disorder. Many seasonal affective symptoms, opposite of those found in major depression, increase in weight gain, more sleep, and we will see the ICD classification. First, it will start 6T60, bipolar types 1 disorder. 6T61, bipolar type 2 disorder. 6T62, cyclothymic disorder, and also other 6T6Y, other specific bipolar disorder or related disorder. These are all the ICD classification, ICD-11 classification of bipolar disorder. We will see one by one. The type of bipolar disorder usually leads its lifetime. Episode of mania and depression typically come back over time. Between episode, many people with bipolar disorder are free of symptoms, but some people may have linger symptoms. There are 3 basic types of bipolar disorder. One is bipolar I disorder, second one is bipolar II disorder, third one is cyclothymic disorder or otherwise called as cyclothymia. These are all 3 major types of bipolar disorder. First, we will see the bipolar I disorder. It is mainly defined by manic or mixed episode that last at least 7 days, or by manic symptoms that are so severe that the person needs immediately hospital care. It is usually the person also has depressed episode, typically lasting at last 2 weeks. The symptoms of mania or depression must be major change from the person normal behavior. And second one is bipolar II disorder. It is defined as an episodic mood disorder defined by the occurring of one or more hypomanic episode and last one depressive episode. It is called as bipolar II disorder. And cyclothymic disorder or cyclothymia. It is the milder from bipolar disorder that involves less severe mood swings over the longer period. It is chronically unstable mood state. Also, people have hypomania and mild depression. It is continuing at the last 2 years. It is called as cyclothymia and cyclothymic disorder. Next, etiology. Etiologies, some scientists are learning about the possible causes of bipolar disorder. The brain and bipolar disorder expected believe bipolar disorder is partially caused by an underlying problem with balance of brain chemical called as neurotransmitters. First, genetic factors. Bipolar disorder tends to turn in a families. 80 to 90% having will get a bipolar disorder. Children with a parent or sibling who has bipolar disorder are 4 to 6 times more likely to develop the illness compared with the children who do not have a family history of bipolar disorder. Some studies shows identically twins have shown that the twin or person with bipolar illness do not always develop the disorder, but it will occurring the percentage of 40 to 70%. Next, the study result suggested factor which said genes are also at work. It is likely that many different genes and person environment are involvement. Next, biochemical changes, it will involving the neurochemical changes like catecholamine abnormalities. For example of norepinephrine, dopamine and serotonin involves one or more sites at brain. And acetylcholine and GABA aminobutyric acid may also play a role of effect. And effect of antidepressant and mood stabilizer also provide additional evidence of causes of bipolar affective disorder. Neuroendocrine etiology. Mood symptoms are present in endocrine diseases like hypothyroidism, Cushing syndrome, and Addison disease. Sleep status. In depression, decreased the sleep between falling asleep and fast rapid eyeball movement period is decreased. Increased duration fast rapid eyeball movement period, delayed sleep also, it will creating and it will causing a bipolar affective disorder. It will seen in the bipolar affective disorder in later. Brain imaging. CT, MRI, PET and have inconsistent but suggestive findings. The findings include ventricular dilatation, white matter hyper intensity and changes in the blood flow also, and metabolism in prefrontal cortex and the cortex callidum. It is affecting the region of brain region of the particularly in bipolar affective disorder. Symptoms. Bipolar disorder, also known as manic depressive illness, is a brain disorder that causes unusual shifting in mood, energy, activity level, and ability to carry out day-to-day tasks. We will see one by one. If patient having a manic episode, it is onset before the age of 30. The mood is elevated, the mood is expensive and irritable mode if patient having manic episode. And also the depression means previous manic episode, the patient mode is dysphoric mode, depressive mode, the patient will having. And speech disturbance in manic present is loud, rapid speech and rhythmic and clinging speech the patient will having. And the patient, if patient having a depressed mode, is interested in pleasure and absence of speech and sitting with alone. And if patient having a manic episode, the weight loss is could only. And if the patient having a depressed mode is loss of appetite, patient will having a constipation, insomnia, libido, suicidal, preoccupational, maybe having the agitation and movement disturbances also patient will having. If patient having a manic episode means hyperactivity, decreased need of sleep and appropriate flight or fight of patient will having. These are all the symptoms presenting in manic episode and also the depressive episode. This is the difference between manic episode and depressive episode. Next, the symptoms of mania or manic episode includes mood changes. One by one we will see. The longer period of feeling high or overly happy or outgoing mood. If patient having a mood changes in depression, longer period of feeling worried or empty. And next, extremely irritable mood patient will having in a manic episode. Feeling and jumping or worried. These are all presenting in manic episode. And loss of interest, activity and enjoyment and including sex also, they are having the loss of interest in presenting in depressive episode. And behavioral changes. What are the behavioral changes presenting in manic episode means talking very fast and jumping from one idea to another idea, having the racing thoughts, being easily distracted. The patient will increased goal directed activities such as the talking on new projects being result. These are the behavioral changes in manic episode. The symptoms of depression presenting in behavioral changes, feeling tired or slowed down, and patient will having the problem of concentrating and remembering and making a decision, and being rest or irritability. changing the eating pattern and sleeping pattern and other daily habits also changing in the depressive episode. Next, we are going to prognostic factors. First, good prognostic factor is acute or adaptive onset and typical clinical features present, and severe depression, well adjusted pre-morbid personality, good response to treatment. These are good prognostic factors. And poor prognostic factors of bipolar disorder is comorbid medical disorders, personality disorder, or alcohol dependence, and double depressions, catatonic stress, and also the chronic ongoing stress. Unfavorable yearly movement making hypochondrial, future presenting, and poor drug complaints. These are the poor prognostic factors in bipolar disorder. Next, management. What are the management we are using in bipolar affective disorder? First, we are administering the antidepressive drug, lithium, antipsychotic drug, electroconvulsive therapy, other mood stabilizers are psychoeducation, cognitive behavioral therapy, family intervention. Let me see one by one. First, antipsychotic antidepressive agents we are administering. For the example of amitriptyline 150 to 300 mg per day, amitriptyline 150 to 300 mg per day. These are all the fluoxetine, sertraline. These are all the common antidepressive drug we are administering in your ward. And lithium. The lithium drug is choice of manic episode and preventing further episode of bipolar disorder. We are using 1 to 2 weeks of period lithium. Usually we are administering the dose level is 900 to 1500 mg per day. Low therapeutic index. Antipsychotic drug, risperidone, olanzapine, quetiapine, haloperidol, and chlorpromazine. These are all the can be used the common drugs of antipsychotic drug in bipolar affective disorder. Indication acute manic episode and delusional depression also we can use antipsychotic drug. Other mood disorder, sodium valproate, other mood stabilizer, sodium valproate 1000 to 3000 mg per day, carbamazepine 600 to 1600 mg per day, lorazepam and clonazepam we are used. Next, electroconvulsive therapy we are administering as per the psychiatric. And also, thank you. Please subscribe and share the video.